Good evening, everyone. Thanks for joining tonight for this webinar in Women and Robotic Assisted Surgery. My name is Dr. Andrea Simpson, and I'm going to be the moderator for this evening. So this is just an overview of tonight's webinar. So I'm going to start with an introduction just around robotic surgery. Then we're going to introduce the members of the panel and have a panel discussion, and then there'll be time at the end for questions and answers. I'm sure most of you are very familiar with Zoom, but if you do have questions during the question and answer period, you can click on the chat box, type your question in, and we'll do our best to get to all the questions tonight. So the purpose of this webinar is really to highlight the role that women play in providing patients with minimally invasive care across Canada, and specifically describe how robotic-assisted surgery is impacting both healthcare providers and patients in the Canadian context. We would like to discuss the following topics today. So what is robotic-assisted surgery? The specific benefits of robotic-assisted surgery for patients, surgeons, and hospitals. Highlight the role of women in robotic surgery and surgery in general, and talk about access to robot-assisted surgery in Canada. We also are going to touch on topics such as teaching, coaching, training, and the learning curve. So this shows the general setup of robotic-assisted surgery. So the surgeon typically sits in a console where the surgeon has controllers to perform the surgery. The surgeon has a 3D camera view, which is especially helpful in difficult cases with high body mass index, surgical scarring, endometriosis, things like that. And then there's a patient cart with robotic arms that is next to the patient. The vision cart allows the camera view, and the surgical instruments are attached to the robotic arms, and the movements transcribed from the surgeon's hands to the surgical instruments. So over 9 million patients have been treated globally with robot-assisted surgery, and there are over 6,500 Da Vinci robot-assisted surgery systems that are used to provide minimally invasive care globally. In Canada specifically, more than 47,000 Canadian patients have been treated with robotic surgery since its introduction in 2003, and over 205 surgeons are trained. There are programs across Canada in 13 cities, over 5 provinces, and there are 33 Da Vinci systems at 29 hospitals. There are several specialties which use the Da Vinci robot, and gynecology is one of them, and we're going to be highlighting that in our talk tonight. In Canada, over 10,000 women have been provided with a robotic-assisted hysterectomy since 2003. Patients benefit from minimally invasive surgery, and robot-assisted surgery can help providers successfully offer this treatment option to all patients. One of the most common pathologies that we treat with the robot is endometrial cancer and its precursor, atypical hyperplasia. And we know that obesity is a significant risk factor for endometrial cancer, with a 10-fold increase in the risk. Sorry, before I get to that slide, there are some benefits of the robot that we'll highlight later today that make it very helpful in offering a minimally invasive approach to patients who have endometrial cancer and a high body mass index. Considering women in surgery, of the surgical specialties, the women are most concentrated in obstetrics and gynecology and general surgery. Gynecologic oncology has the highest proportion of women as a specialty. And urology, although it is one of the largest surgeon groups, actually has the lowest concentration of women surgeons. In Canada, you can see that the proportion of all women surgeons in the specialty of gynae and gyne-oncology pretty much matches the proportion of women who are robot trained. This is different than other specialties where the proportion of women are lower. And we also see that within those specialties, the proportion of women trained on the robot are much lower than would be expected. There's been a lot of literature recently on specific challenges that women face in surgery. Women report more occurrence of gender bias in medicine, and part of this is what has been referred to as the hidden curriculum, with fewer women entering surgical specialties. Although this has improved with time, and specifically in OB/GYN, we still have a ways to go. We've also published literature on the sex-based pay gap, with female surgeons making 24% less than male surgeons per hour spent operating. And one of the drivers of this difference is that female surgeons were found to have fewer opportunities to perform the most highly remunerated procedures. More recently, we published on referral patterns between male and female surgeons. And there is a propensity for male referring physicians to refer more commonly to male surgeons, whereas female referring physicians are about equally likely to refer to a male or female surgeon. So I'm the moderator for the discussion today. My name is Dr. Andrea Simpson, and I am a minimally invasive surgeon at St. Michael's Hospital and an assistant professor at the University of Toronto. This photo here is me with my colleagues at St. Michael's Hospital. So there's 4 of us here who perform robotic assisted surgery. I'm at the front here, very pregnant in this picture. I didn't think that this was going to be a picture that would be used over and over again, but here we are. And then we have Dr. Deborah Robertson, Dr. Sarah Kivas at the console, and Dr. Alicia Nensi. So I am fellowship trained in robotic surgery. I started my practice here in 2018, and we use the Da Vinci SI. I primarily use the robot for hysterectomy and myomectomy. The benefits, as I alluded to earlier, improved visualization, wristed instruments. The surgeon has access to a 3rd arm. It lowers operating times, and we did perform a systematic review that the data is shown here that basically demonstrated that compared to laparoscopy, when a patient has a robotic surgery, they have a lower conversion to laparotomy rate for obesity-related indications. We're going to move on now to the panelist introductions, and we're going to start with Dr. Helen Steed.
Hi, thank you. So I am from Edmonton, and I'm looking at the other physicians I'm speaking with today, and I think I am the oldest on this group. We started robotics in Edmonton before 2010, actually, so over a decade now. And when we first started, this picture, which is they inputted 2 of the surgeons. We're missing just 1. There's actually 6 of us that do robotics in Edmonton. We're all gynecologic oncology trained, and we at the top there is Dr. Capstick. She's actually retiring within the next few years. She's given us her heads up and wind down plan. It's funny, in this picture, Dr. Wells in the middle was also pregnant when we were doing our fundraising for the robot. And then myself. And then since then, we've had Dr. Krista Aubrey as our newest recruit. She's in the bottom left corner there, just started July 1st with our team and finished doing her robotic training with us in the spring. And Dr. Sophia Pinn is currently home on mat leave right now, just had her 3rd baby in October. And the one we're missing, I said to Janelle, we have to get a good headshot of you to add. Janelle Sabrin is with our team, actually going on 7 years now. So all 6 of us are gynecologic oncology trained and do robotic surgery at the Lois Hospital in Edmonton. I think you advanced the slides, right, Andrea?
I do, yeah.
Okay. So yeah, we started, as I said, back in 2008. It's funny, I don't have a colleague on from BC, but we were hoping to be the first ones to do a gynecology case in Canada. Got scooped by a day by our Vancouver colleagues who did one the day before. Dr. Capstick and I were the 2 at the time that went away for our training, and since then have recruited the other 4 to join us. We are over 2,000 cases at our site. And when we first started, which I'll talk a little bit about when we're talking at the panel, but we actually used to borrow or share, whatever term you want to use, with our urology colleagues who were actually super supportive. And we only had a day a week to do a couple cases. And now we fundraised and have our own robot specifically for gynecology, and we use it every day of the week. We do primarily endometrial surgical staging, some very early microinvasive cervical staging, some ovarian staging also, but mainly it's used for the sentinel lymph nodes because we have the firefly attachment, pelvic and peritoneal dissections, hysterectomy, and staging. And I would say that it's allowed us, as you've alluded to do more complex patients, such as the higher BMIs for sure, and to have a decrease of post-op complications for them. All the benefits we're all well aware of lower blood loss and rapid recovery. And on the far right side of the screen, that probably is the biggest benefit that we are liking to say COVID has also taught us. At the start of COVID, looked at our same day discharge rate, and we were about 25%. And it really taught us when we had to get patients out of hospital because beds were a premium. We actually have our same day discharge rate now at 70%, and we have a quality improvement project looking at that. We probably offer robot surgery for almost 90% of our endometrial cancer patients also. So it's the first go-to. And the reason to not offer robotics is usually because the uterus is too big. There are really no other limitations to it.
Okay, great. I don't know if you remember, Dr. Steed, but I did an elective with you when I was in medical school, even though I didn't go into gynecologic oncology. I would say you were actually the third person I'd ever seen use the robot. And the first was Dr. Joan Murphy. The second was Dr. Guylaine Lefebvre. So I had the opportunity to see 3 women surgeons first on the robot. And I really do think that representation matters and that it helps you see yourself doing that in the future. So thank you very much for that.
Mm-hmm.
We'll move on to Dr. Susie Lau.
Hello, good evening, everyone. I think you're seeing me tonight, but in fact, you were supposed to see Shannon Salvador, my colleague, who unfortunately had a personal issue to attend to. And so I'm sort of filling in our team at the Jewish General Hospital, McGill University, there's 3 of us, but 2 out of the 3 of us are women. So there's Walter Gottlieb, Shannon Salvador, and myself, Susie Lau. Can we move to the next slide, I guess? Thank you. Oh, okay, it's the first time I've seen this slide. Actually, we started our robotic surgery in December of 2007. And currently we operate with the Da Vinci Xi, and our hospital has 2 of them because we have so many subspecialties actually using the robot. And what I do is a lot of patients with ovarian cancer. I guess at this point in time, our specialty is really focused on patients who are obese or with a body mass index of over 30, which allows us to do their surgery in a minimally invasive fashion such that they leave the hospital usually on the same day with less complications, less infection, and they get back to their usual activities in a much quicker time than the traditional route when they have open surgery. And it allows us to do surgery on patients who are much heavier, where by laparoscopy, it would be much more difficult. We have also concentrated a lot in our center on offering patients with advanced ovarian cancer neoadjuvant chemotherapy to reduce the volume of tumor. And thereafter, after about 4 cycles of chemotherapy, then we do the rest of the debulking surgery, removing the rest of the cancer using the robotic assisted route. And what we have found is that we're probably at this point in time treating about 80% of our ovarian cancer patients in this fashion. And we've also published our data that's demonstrated that the survival seems to be the same, whether they have surgery with the robot versus open surgery. And so, I mean, that's where this technology has really changed our practice in Montreal.
Great, thank you very much. And I think one of our surgical fellows just joined you at the Jewish General as well, Dr. Ben Lolo, who I think is here tonight also.
Yes.
So we're a small family in robotics. And our next panelist is Angie Stackhouse. So Angie, if you want to unmute yourself.
Hi, thank you very much for having me this evening. Yeah, so I'm Angie Stackhouse. I'm the robot coordinator at the Ottawa Hospital. And just give a little bit of background. I see a picture of my team up there. We kind of snapped this on the fly yesterday morning in preparation for this. So that's just a few of the nurses that I could gather in the morning after report with our brand new XI. And So as you can see, mostly women. I think we have approximately 40 or so nurses trained, and of those, I think 3 are men, and everyone else is female. So yeah, is there just a little bit about my background? So yes, I am the robotic coordinator. I'm also the care facilitator for urology at the Ottawa Hospital. I've been nursing for well over 25 years and in the operating room for 20. And of that, 18 years as a care facilitator in various surgeries, services. So I did ENT and plastics and thoracics and urology and breast, and then I ended up being the robot coordinator 7 years ago, as well as the CF for urology. So just a little overview of our robot program. So we had a Da Vinci SI, and that was in service for almost exactly 10 years. And we performed nearly 3,000 robot-assisted procedures with the Da Vinci SI, including over 900 women. So we at the Ottawa Hospital are currently working in multiple specialties, including gynecology, urology, and ENT. And as you can see in this pie graph here, that the bulk of our patients are urology patients. So just some of our program highlights. Summer 2021, we did actually expand our urology patient population to include partial nephrectomies. And then in December, actually a little over a week ago, we started to launch into our Da Vinci Xi. The next step for us is expanding to thoracic. So we do have 2 systems that we just purchased, and only one of them is currently in action, and the next one is coming in early New Year. So one thing in the very short period of time that I was able to notice almost immediately with regards to OR efficiency, as you can see there, I track our OR ready time. So the time that we start our setup to the time that we would be ready and able to bring our patient in the room. And you can see a significant reduction in our ready time from the SI. I think it was around 12.5 minutes to now the XI. You know, we've seen even 4 minutes, 6 minutes, and you know, that's with the learning curve as well. Of just getting going on the new system. So I thought that was an interesting point to share.
That's incredible. Yeah, that's we know how precious OR time is always, but especially these days.
Exactly. Yeah.
All right. And then the last person on our panel is Tamara. Tamara, did you want to unmute yourself and just share a little bit about your experience and journey with the robot?
Hello, good evening, everybody. For me, when I think I was given the information, I mean, obviously my surgery, a robotic surgery, was because I myself am obese, but I never knew how uncommon this technology was, or so the very fact that it was available to me and it was an option, quite grateful, absolutely grateful for that. And because I worry, I tended not to heavily research it, but I had the utmost faith and trust in you because you're my doctor, as well as the exceptional staff at St. Mike's. And everything about what I went through was just perfect. I couldn't have asked for anything different. And again, absolutely grateful for the fact that this procedure and the technology exist.
Perfect. Thanks, Tamara. So we're going to go into our moderated questions. So I'm going to start with Dr. Steed. So Dr. Steed, the first question is just around how you were first introduced to robotic surgery, and as a surgical robotics pioneer and leader of an all-women surgical team at the Lois Whole Women's Hospital, can you describe how your team supports each other to deliver robotic surgery in a safe and efficient way?
Yes, so how I was first introduced to it actually was at a GOC meeting. That's one of our national meetings for our gynecologists of Canada. Society, and is actually Danny Minogue with Minogue Medical is there and had a robot kind of for us to sit down and play with. And then I had just completed my fellowship at the time. It was probably 04. I was coming back on staff, and I actually spent my last 6 months doing MIS surgery down in California as an elective as my fellowship. So I was very much into and believed in the benefits of MIS surgery and doing everything laparoscopic, and just looked at this as, like, I call it the Porsche of laparoscopy. So that was my first introduction. And as for supporting each other, I just think it's one of those things where you can't do it alone. It's like any kind of being part of a team, whether it be speaking about surgery or patient care. I think as for support, things such as simple as going to courses together. Right before COVID ended, Dr. Sophia Pin and myself went down to a course in California, and it was more that she was junior, she's under 5 years on staff. And for me, it was like a refresher. Like, I've been doing this for, as I said, well over a decade, but it was just nice to go together. You bounce things off each other, learn together. We have every one of our staff we brought onto our team since Dr. Kapsik and I started, have all done during their fellowships electives with us. So we could learn from the whole team, not just us. So exactly as Angie said, the setup with the nurses, we have a specific nursing team in the OR, the efficiencies of the OR, and then right down to the skill set on the robot itself. So we've helped have them trained in fellowship. And then when they start as junior staff, we've mentored them almost that fly on the wall, where we've sat on the row, kind of in the room, let them be at the console. We're just there to bounce questions off of a point on the screen where we think things could be different. And then, of course, during COVID, we have a very tight text chain in the mornings. If someone can't be at work or who's on the robot, we cover each other. So it's just about that team environment.
Okay, thank you. The next question is for Dr. Lau. So Dr. Lau, minimally invasive surgery has been shown to have value for all patients, especially women with obesity who require hysterectomy. And laparoscopic surgery is often challenging for these patients. Why do you believe that it's important for patients to have access to robot-assisted surgery? And what are the benefits of robot over conventional laparoscopy?
Okay. So thanks. This is a great question because a lot of people who were doing laparoscopy would say the same thing. I can do that by laparoscopy. Why do I need the robot? But the reality is there was a huge study conducted on endometrial cancer patients where they compared laparoscopy and open surgery. And when they looked at laparoscopy and open surgery, they said laparoscopy is so much better. Patients are getting home and recovering so much quicker. This should be the standard of care. However, in that same trial, there were a lot of patients with a higher body mass index who happened to have been converted to open surgery because their surgery could not be completed by laparoscopy because it is much more challenging to operate on patients with a higher BMI by laparoscopy. However, what we have found with the robot is that it really takes the difficulty out of minimally invasive surgery in terms of operating on patients who are obese or who have a high BMI. And when we published our data, we looked at how the patients were feeling. We looked at all of the complications. And what we found was that if we looked at just the women who had a high body mass index compared to women with a normal or lower body mass index, we found that there was no difference in terms of complications or length of stay, and such that patients who are obese benefited equally from the robot and were comparable to women who were not obese. And so as a result, we have a technology that we can offer this benefit to all women. And I think it's really important that as healthcare providers that we do extend those benefits to everyone.
Okay, thank you. Before I read the next question, if the audience, people in the audience have any questions, please feel free to put them in the chat at any time, and we'll make sure that we get to all the questions throughout the talk tonight. So my next question is for Angie Stackhouse. So introducing innovative technologies such as surgical robotics can be at first daunting to surgeons or hospitals. Your hospital recently upgraded your Da Vinci surgical robotic system, as you were telling us, and acquired a second system to expand your program. Can you describe how your team has adapted to using this new technology?
Yeah, well, as I mentioned earlier, we started using our XI just last week, but we actually received the X and the XI back in late October. And of course, as you can imagine, there have been a lot of moving parts to coordinate the upgrade and expansion, and from logistical services to facilities to, you know, meeting with our surgeons and management and nursing teams and all of that. We then did decide, though, that we were going to jump right in and start with the XI, even though the X is a little more similar to what we were used to. We wanted to just jump right in and get going with the XI. So that's what we decided as a team. Our second system won't be ready until the new year sometime, but that's how we decided to proceed. So we're still in the infancy stage of using the new robot. And training, of course, is ongoing. I'll just give a little overview of the training process that we established 10 years ago. So with the SI, it worked. And so we just decided that we were going to keep going with the same training protocols and processes that we've been doing for the last 10 years. So I typically hold maybe 2 to 3 training sessions for nurses every year. And I keep the numbers really small, up to four nurses at a time. Resident training, I will do resident training as necessary or once a year. And if I can't do it, then certainly our colleagues with Minogue Medical will help me out a little bit with that. Sometimes with scheduling, it's difficult for me to get the training done for everyone. So the first step I usually initiate with the learners is for them to complete the online modules and give them just a little bit of an introduction to what it is that we're going to be doing. So then the second phase would be a hands-on session. And with the nursing team that I have in place, typically I find that, 3 to 4 hours works. And that gives, with a small group of 3 to 4 people, that gives everyone a little bit of time for hands-on. And so then in the third phase, they would then, be buddied in a room with myself and another stronger robot trained personnel so that we can focus on their training. So of course, keeping that in mind, I wanted to jump right in. And as soon as we found out we were getting the XI, I went on and did that just myself. I did the online modules. And then as soon as we got the robot in October, I worked with the reps with Minogue and had my own hands-on training. The 2 robots were sitting in an empty operating room since October. So I've been pulling nurses in here and there as we could accommodate, just to get as many people trained as possible. And so I'm still in the process of training everyone. We did have some sessions arranged with our surgeon teams as well, and residents. And then of course, the evening before we were launching, we did a dry run with everyone. So we swapped out, the SI was being used for 2 partial nephrectomies that day. We cleaned the room, swapped out the old, brought in the new, and went and did our dry run. And so everyone could have like that hands-on feeling. And we found that, anytime we implement anything new, whether it's a new procedure or the new robot, it really certainly does help. So I have to say that support from Minogue has been of the utmost importance, and I couldn't have gotten all of this going. The launch has been such an easy transition to this point. So I do suspect that once we implement the second new robot in the future and have 2 rooms running, I'll need probably to train many more nurses. And so we're looking forward to that expansion for sure.
That sounds great, and sounds like great leadership on your part as well.
Thank you.
The next question is for Dr. Steed. So the COVID-19 pandemic has had profound impacts, as we all know, on the provision of surgical services across Canada. And you talked about this a little bit before about how you have been successful in having same-day discharge for most of your robotic patients. Could you tell us a little bit more about how you see robotic-assisted surgery playing this role in the ongoing recovery of the surgical backlog in gynecologic oncology?
Yeah, definitely. So I think it's one of those things where when push comes to shove and when we had all these changes with COVID, it made us kind of sit back and go, well, why don't we discharge more the same day? And it was little things like, we service Northern Alberta, so a lot were driving home. Well, a lot can stay with family or stay at a hotel because their spouse is at the hotel anyhow while they're in hospital. One of the big issues that we looked at and we've overcome, and it's been great, was our really large BMIs. And if they're on a CPAP machine, we'll do first case of the day. And then we actually were able to persuade and work with management and operations to extend the recovery time in our post-op kind of day surgery wards. Instead of just closing at 3 or 4 o'clock, they extended the hours up to 9 to 10 p.m. So then if you were off the robot on that first case by 9:30 or 10 a.m., you've actually had 12 hours of watching that patient recovery. So then if anesthesia is happy and signs them off, you can actually safely send those patients home. So it just kind of helped us relook at things. And so, yeah, we set a goal. We started a quality improvement project. And we had buy-in. We kind of spoke with the nurses in pre-op counseling because, as I say, it's all about expectations. So if the patient expected from the first day they met as a surgeons, we tell them you're going home that night. Then if the pre-op counseling nurse tells them you're going home that night, they come prepared to go home that night. It's about the expectation set up. And it was simple things like when they leave the OR, we take the Foley catheter out. So they go to recovery room and the nurses know they're not going to have a catheter in. It's just simple things like that, making the process move along. And so we identified, we thought, let's set a target goal. And so it definitely helped during COVID because there are lots of times where we were told you can only do patients who are going the same day. And so a lot of people thought, oh, well, gynecology can't do that. They got the big, major cases. And we said, yeah, we can do that with the same day discharge in the robot. It showed a lot of our general gynecologists who, for laparoscopic procedures, are keeping patients overnight. So they've kind of started their own now and follow suit kind of thing, because beds were at a premium during COVID. And so I think it just helped us see that we can catch up with the backlog. And so we aren't blocked now by saying we can't operate because there's not a bed. So it's just, I think that whole idea of setting a goal, engaging the entire team, setting expectations for the patients, and then you're really proud to see the outcome you have.
Okay, wow, that's, yeah, really impressive that you can send so many of your patients home and that you can finish your first case so quickly. Okay, so the next question is for Dr. Lau. So Dr. Lau, leadership and mentorship are important predictors of who will choose surgery as a career. Can you describe how you help trainees and students become more comfortable with surgery and encourage adoption of medical technologies such as surgical robotics?
Okay. Well, firstly, I participate in a lot of different shadowing programs. And at McGill, they have shadowing programs at all levels. And it starts with undergraduate students. So students who haven't even chosen to go into medicine can do shadowing programs where they follow either a surgeon or a physician for the day. A lot of students ask what I do, and when I tell them that I do a lot of robotic surgery, actually the first thing they want is to shadow me during one of my surgery days with a robot. So from undergraduate students to medical students who do electives, to residents from various programs, and even various observers around the world, they come to participate in shadowing programs at our center, specifically to see robotic surgery. And I think it's really important that more women, more students get exposure to the robot, because it's like an aha moment. Anytime you have any student, any trainee that hasn't seen the robot before, come and have them sit down on the console. In the first 10 seconds, you hear, wow, because the vision is so much better. They understand that we see in 3D, that we have such great ability to move and see and operate, that they're really dumbfounded. I think the final thing is training of physicians, and mainly what we do is train a lot of gynecologic oncologists. And I think we were the first program to really integrate robotics training into our fellowship program when I started with the program in 2012. And so since then, we've graduated many qualified robotic surgeons and hope to continue to do so.
Thank you very much. The next question is for Tamara. Tamara, can you describe your initial thoughts? I guess when I informed you that robotic assisted surgery was an option for your treatment, and if you could just give us a little bit of a description of your experience and recovery. Tamara, I'm not sure if you're muted at the moment.
Oh, I'm sorry about that.
Oh, no
There you
problem.
are. Can you? Okay. I'm trying to reflect back, and I guess first off, the just being diagnosed with cancer. So then from there you go into, okay, operation. And then you realize, wait a second, I'm too large for operation. You don't think of stuff like that. You just think if you get sick and if you have to go for an operation that you can. And then you're like, no, it's going to be robotic assisted. And I was just like, what? The whole concept of robotics and the use of, and then knowing just what it can do and what it did for me and what it can do for so many other people out there is, I mean, it goes back to just, it's, for me, it was mind blowing. And I just feel lucky and grateful that it was something that was available for me and that I could have it. And in regards to the recovery, again, I never even knew myself personally that I could have, had a longer recovery time, but my recovery was very minimal. It would be just like, how you have your bruising and your pain, which is normal with any usual type of surgery. But everything for me was, it actually, I couldn't have asked for anything better. So it falls into the category of just being honored, like privileged, lucky. And because I think I spoke with you and just said, I just assumed that this was a commonplace practice. I was not aware that this is not as widely available, and it should be. So yes, that's what I have to say on that, if that's all right.
That's perfect. Thanks so much. The next question is for Dr. Steed. So surgical robotics is not directly funded in all provinces. And as a result, surgeons often have to partner with hospital foundations to raise funds to support the acquisition and use of this technology. Can you provide any advice around how your team was able to fund the first robot system in Canada dedicated to women's health?
Yeah, so I would start by saying you get involved. So you actually meet with the foundation, you speak with donors, you're actually there. And I think some physicians, if you've never been exposed to this, especially during medical school training, feel uncomfortable about it. But you have to remember it's advocacy for our patients, and the foundations are there to support things that can't be covered by operations. Is an excellent example. The other thing I'd say is also to learn from others, and to also team up and kind of ask them for their support. So we were fortunate in Edmonton that urology had already started robotics, and we have a good working relationship with our urologists. And it was almost like when the urologist said to me, well, what's good for the men if they get a prostate, why is it not being offered for the women? And he knew I'd gone away and done this MIS training and then in my fellowship. So he said, why don't you come over and watch one day? And I will never forget, exactly like Susie said, Dr. Lau explained, it is a total aha moment. And I watched him do a prostate and the nodes, and I was like, wow, you are right. We should have this for women's health. So we are just starting to build the Lois Hospital. So it's also great timing for us to kind of have something to say, well, what's special about this hospital, right? And so we got involved with the foundation. I met the chair of the campaign. We offered to speak with donors. We offered to give the medical side so you can actually see that and have that aha moment, look at how this robot works. And just, I think, be willing to get involved and not shy to explain why it's a benefit to patients, how it's going to make a difference. and why we need the support, because it is an expensive tool. And so, you know, to be able to have those base dollars and base funding, and for donors to feel part of that. So yeah, we continue to do talks for the foundation. We've shown before COVID, of course, when we could bring people in for a little tour, we've actually had the donors come in to be able to see what their finances did after hours and do like a little teaching session. So I think it's just not being shy to get involved. And then, like I said, learn from others ahead of you. So if there are other specialties using the robot or having it selected for their specialty, asking them how they did it. So that's my advice on that.
Great. The next question is for Dr. Lau. So ensuring weekly access to a robotic system can be a challenge for some surgeons and specialties. Can you please describe what your team did to gain regular access to robot-assisted surgery system at the Jewish General?
I guess, well, I mean, for us, all of this started in November 2007, when the robot was first delivered to our hospital. And it was negotiated from the start that 4 surgeons or 2 services be trained. And there were 2 urologists, and luckily myself and Dr. Walter Gottlieb, my colleague, we were the first 4 surgeons to be trained. And approximately a year after we had the robot with us, our hospital had an audit of how we were using our OR time. And so we were audited by an external source who looked at how we were using our OR time and basically suggested that we were on the cusp of maybe leading robotic surgery in Canada. So I mean, our hospital really jumped on board. And then at the start, when we had 20% of our operating time as robot time, that almost overnight switched to 80% robotics time. And so as a result, I would say that about 80% of all our surgeries now are done robotically. And I think the other thing that really helped us to get regular OR time was that from the very first case we did up until today, we have a prospective running database, which means that we regularly are able to keep track of how patients are doing, what are our statistics in terms of complication and the utilization of our OR time. Because not only is it important to prove yourself in the beginning, but it's also important to prove yourself regularly that you're being responsible with your OR time and how you're managing that time with the patients that you have. So as a result, I would really suggest that people who have difficulty with being able to get regular OR time, keep a track of your cases and collect this prospective database to be able to show people what your outcomes are. And then that is practically self-explanatory that you would need more robot time.
Great, yeah. The next question is for Angie. So Angie, you've been leading a program for over 7 years. Can you describe any lessons that your team has learned that enable surgical teams to provide quality care safely?
Yeah, so planning is huge. So upon implementing our robot program 10 years ago, an emphasis was placed on planning. And this has continued to be the foundation for the introduction of every additional service and procedure that has been brought on board along the way. So we do have a steering committee. And we hold a little bit more regular now meetings along every month to 2 months. And they've been crucial for discussion related to robot processes and protocols and, the next steps sort of thing. So communication has been integral in the success of our program. Many multidisciplinary teams have been involved at each step. So from nursing, surgeon, anesthesia management, and our logistics department, our medical device reprocessing department. So, representative of all of these departments have been at the table of our steering committee meetings, and so important in both the development of our program as well as sharing of valuable information, anything that comes up along the way. A huge thing for us, and I think what has contributed to our efficiency, is standardization. So when developing protocols and steps for each procedure, we did develop standardized approach that was agreed upon by all members. So keeping things systematic and standardized. And so there's no question, you know, we do everything the same way every single time. And I really do feel that, you know, eliminates any confusion regarding the way that things should be done, and everyone's on the same page. And it does help, I think, with increased efficiency in the OR. So training, as I touched upon earlier, each team member, you know, training of each team member has been critical. And so hands-on training, site visits for, you know, the surgeons, and mentors and proctors and that sort of thing, and dry runs, they've all been so valuable for us and for our skill development. In fact, today our thoracic team is in Hamilton was in Hamilton doing a site visit for the launch of their part of our program. So one big thing as well, I think, is having one robot coordinator. So, you know, that's me. I'm one person. I'm responsible for all of everything robotics related to for our particular facility. So, you know, there's no question on, well, whose responsibility is that? Well, it's me. So, you know, that way I think, you know, nothing gets missed along the way, and the services and the surgeons, they know who to contact if they're looking for, you know, robot time. Then I'm the one who, you know, keeps track of the availability of the robot. If it's not being used one day, I can kind of throw it out there for them. And if they have OR time, they'll pick it up. And, you know, I think that's how we've been able to get more patients done, which is really important. And I like to see it being used. So if the room isn't scheduled on a day, then we can for sure try to get it done that way. So I did, and in my initial slide, there was some data tracking. So I do keep track of all of our stats. And so various times I document key times throughout the day. And I think it has been useful in allowing us to see how we can improve on efficiencies. So as mentioned, our OR setup time has made significant improvement. The other thing, so the people, arguably the most important factor to mention, and the biggest reason for our success as a program. So I surround myself with some of the best, and you know, our team is patient focused, motivated, and driven to provide the best possible care for our patients. And ultimately it is about our patients and delivering safe and excellent care to them. So I'm proud to be part of this program. And when I hear some of our newer nursing team members saying that, you know, one of the contributing factors and the reason why they got into perioperative nursing was because they wanted to be part of our team. And so for me, that's a win for sure. It's a bit of a magnet to get people coming to work in our facility for the robot specifically.
Awesome. The next question is for Dr. Steed. So surgery can be physically challenging on a surgeon and can cause strain, resulting in physical symptoms and discomfort. Has leveraging surgical robotics helped in any way?
I think it's an excellent question, because actually I'm just starting to have issues with neck and headaches, and I definitely notice a difference when I have my robot day. I just want to echo, actually, before I ask the question though, Angie's comment about efficiencies and the nursing team, because when you're asking about, you know, how quick we get off the robot, it really is that setup and the team. So we have a dedicated robot team. The nurses are trained. We try and keep similar, you know, nurses in the room. We have surgical assists. Our residents all get training before they come on the robot with us, because we feel it's very important. Playing with a expensive toy, as we called it when the residents first came to work with us. And so the efficiencies in that change over time, I agree, by having a team and having a process. We've had some days where we do 4 robots in the day. So it definitely, I want to echo what Angie said about having that well-functioning team. But yeah, as for the surgery physically challenging, I have been on staff over 17 years now. And so if I go back and count all my training, I'm well over 25 years operating. And we all know as pelvic surgeons, especially on open cases, you're standing at the side and your head's tilted because the patient's tilted to look into the pelvis. And so, yeah, I just actually recently, it was interesting when I saw that question, I had to giggle because I've just started seeing my physio for IMS in these specific muscles because of tension headaches. And I definitely notice a difference, hands down, when you're sitting down, your hands are level, you're looking in the scope, you're not getting these awkward positions on some of those bigger, longer cases that we do if it's a big mass and we're doing it open. So I think that it's interesting because it's something we don't really talk a lot about. It's always the patient focus, which obviously that's our training and how we feel as physicians. What can we do for better patient outcomes? And so we talk about, faster healing and faster recovery and less blood loss and all these wonderful things minimally surgery offers our patients, which I think should be the forefront. But I think it's okay to also mention ergonomics of your surgeon and the lifespan of your surgeon. So when I was in California doing my elective, two of the highest volume, and this was laparoscopic, so this is not robotics. One was out with a shoulder surgery and the other one went out with an elbow surgery. And they talked about how, the lifespan of a surgeon and how many, injuries they may have themselves from just repetitive, movements that we do. And so I think it's okay to mention that ergonomically, I don't think we can deny, just sit and watch someone do a robot case and then watch them do laparoscopic or open. So I think we should hone in on that as another really good benefit for our surgeons.
Absolutely. And I think there's more and more focus on physician wellness and ergonomics for us as well. Dr. Lau, your team has done a great job collecting health outcomes and economics data, and you've had several publications on cost effectiveness of providing robot-assisted surgery. Given that women's health is often underfunded, has this work helped your team be able to provide robotic surgery?
Yeah, definitely. So being one of the first centers in the country having access to this technology, our team, our Gynecology team, felt that we had the responsibility to assess and track progress using this type of technology. And that's where that prospective database comes from. So we use that database to look at various outcomes, looking at survival and effectiveness data for the conditions that we treat in Gynecology, looking at complication rates, length of stay, quality of life for our patients. But of course, the cost effectiveness was very important. And having that prospective database allowed us to be able to quite easily actually assess the cost effectiveness of what we do. And we did it on a case per case basis, meaning if we compare robotic endometrial cancer managed robotically versus laparoscopically or even open, we compared the costs. And over a longer term, we could easily see that doing the robotic surgery led to cost savings. And then if we stop talking about individual surgeries, what about just having the robot at the hospital? We looked at the costs of having the robot over a 10-year period at our hospital versus not having the robot for the 10-year period prior, assuming that the rough costs of things are otherwise the same in terms of hospitalization. We're also able to find that because our surgeries were most often done with the robot and had shorter hospital stays, that overall over a 10-year period, definitely having a robot saved our hospital more than at least $1 million. And so I think in terms of healthcare budget and so forth, it's definitely something our administrators look to and has definitely helped us to get more robot time.
Great. And then I have another question for Tamara. Can you describe how you prepared for surgery and how the experience has impacted your life? And do you have any advice for other patients who are undergoing a robot-assisted surgery?
In terms of actually how I prepared for it, I have to be honest, I am a chicken. So as much as all the wonderful literature was out there, in order for me to, because I accepted that the only way through this was this surgery. So in order to not psych myself up or out, sorry, I didn't want to know too much other than the basics that I was told from you and from, you know, just the team that you meet and whatever have you. And I was happy with that. And none of the procedure and what was going to happen, I wasn't scared of that. I was just probably generally scared of, oh my God, I have to do surgery. So I was okay with that, and a little chatty, if you remember, until the anesthesia hit in. Tend to talk a lot more when I'm absolutely nervous. So that part, I did the mind over matter thing, you know, just it's got to be done. It's necessary for my survival type thing, and just focused on that and trusted in the science and the technology and the experience that came with it from yourself and others at the hospital. So that's how I prepared for that. And what was the second part that you wanted to know? Just the overall recovery, or
Just any advice for other patients who are undergoing robotic assisted surgery?
okay. I think the biggest reality is just finding yourself with a diagnosis, such as why you have to be here. For me, I was shocked. My age is 52, so it wouldn't have impacted me, say, as much as somebody who's younger who is still of childbearing age. So that's just more to deal with for somebody else. But again, going towards the whole procedure and having that available, not even realizing that this was something to be lucky to have. I mean, I have to stress again, when we all grow up and we become this or that, nobody says, I want to be fat. Nobody even realizes just how much being obese actually has so much of an impact on more than your everyday things. You just think that if you get sick and if you need help, you have that there. I remember when my gynecologist said, well, you'll need surgery, but you can't have standard surgery. And I had this dumb look on my face as to why. And she's like, you know, because the equipment won't fit you. And then I'm like, that what? So then to find out that enter robotic surgery, enter that this procedure exists. And then, like I said, I took this for granted. I thought that this was a common thing available to everybody. And then after talking with you for some time, you're like, no. And I don't know, the best thing I can think of for anybody who actually is going through this or has to deal with this is that trust in the process, trust in your staff and your doctors. Don't be afraid, even though that's easier said than done. And know that it is probably one of the better procedures. It definitely, from just my own experience and just from what I've seen and what I've heard, it definitely reduces your recovery time. So it just seems like all of this is a win. And lucky and grateful again. I'm stressing that. I am just very fortunate and happy that this is available for not just somebody like myself, but for anybody who needs it. So I hope I addressed that okay.
Thank you so much for your honesty and sharing your experience. I think all of us robotic surgeons here feel very strongly that the technology exists. We know patients will benefit from it, so we would like it to be more widely available. Absolutely. I'm cognizant of the time, but I'm just, there were a few questions sent directly to me. One of them is in the chat. I think that a few people have responded to, so maybe we'll leave that one in the chat. One question was around a Gynecologic fellow training in a program where robotics is not offered. What advice do you have for training opportunities in robotics in Canada during fellowship training? Maybe either Dr. Steed or Dr. Lau, you could take that one.
I can answer for Edmonton, and then Dr. Lau can let me know if she agrees, supports it. But we actually don't have a Gynecology fellowship program in Edmonton. Partly philosophy of our center, it's always been very resident focused back to the day when I was a resident, and it's kind of maintained that way. And also we have a fellowship just south of us, 3 hours in Calgary. So we, though, very much offer electives. And I think it's kind of gotten out there to places like, for example, Dr. Lau, if it's part of her program, she already has fellows being trained there, right? So it's hard to go there. But we don't have fellows. So if someone in Calgary or BC wants to come do 2 months, we ask for a minimum of 2 months because we feel we need to see them, which I'm sure Dr. Lau would agree. You want to build up some momentum. But we've probably had in the last year, even during COVID, 3 fellows come to electives with us. And before COVID, another 3 that I can count in my head. So we just asked them to go through our division director. And if we can make the time work, we're happy to have them at our center. We just try and make sure they know their focus is robotics. As I said, our residents really love their time operating with us too.
I guess for us, most of what we do is robotics. So when we ever have medical students or residents or other observers come, most of what they're going to see from us is the robotics. And in terms of getting training, we have a fellowship program in Gynecology whereby our fellows are trained to do robotics, and a lot of them actually go back to their hometown or their country and start robotics programs. And so really the only way is to, if you want to have that experience, you just have to seek out programs that actually have the robot and use the robot and do electives. I agree wholly with Helen that it does take a certain amount of time for surgeons to trust other surgeons to operate on their patients. So if you want to have a hand at the robot, you really need to do electives for an extended period of time.
Okay, great. One of the questions was around what makes robotic surgery more effective for folks with a higher BMI. Briefly, when we do these pelvic surgeries, we place the patient in steep Trendelenburg, so a head down position where all it puts a lot of pressure on their respiratory system, and it can be very difficult for anesthetists to provide adequate ventilation. The robot has a bit of a lifting effect on the abdominal wall so that we can lower the pressure inside the abdomen to much lower levels than we would with laparoscopy. And that can make laparoscopic surgery more feasible. Some of the other things, the wristed instruments, the 3D camera, and the utilization of a third arm for the surgeon. The next question was from a participant who is a robotics engineer, so a very male-dominated profession, applying to medical school this year, asking, how do you think having an engineering background can help make better robotic surgeons or even physicians in general? If any of the panelists want to respond, we also have some people from Innov Medical here who could also jump in. If anyone wants to take this question.
That's a loaded question. So let me ask if the engineers play a lot of video games, because what we do seem to know is that people who do play video games at least an hour a week, I think there was a study that demonstrated that those who played at least an hour a week of video games were actually better at laparoscopic surgery. So similarly, if engineers, most of my engineer friends play a lot of video games, I would expect that is one big component on how they would be better robotic surgeons.
All right. So I just want to be respectful of everyone's time. So perhaps we'll end the questions here. Just a few final thoughts just to end the session. So kind of the broader topic of promoting women in surgery. The literature is full of ideas around improving equity in training, encouraging women to consider surgery early in their careers. And as Dr. Lau talked about, lots of shadowing and mentorship programs to attract talented women to the field. Using formal titles at presentations, reflecting on our own practices and our own areas of gender bias that we may not be aware of, promoting women in leadership positions, zero tolerance for sexual harassment, which unfortunately is still very common in medical training, and other interventions that could reduce discrimination for issues that are more specific to women surgeons. There are some resources for women in robotic surgery that are listed here, and then some patient support resources as well. I don't know if any of the panelists want to leave any last thoughts or comments. I want to thank everybody for attending tonight and for a really great discussion.
Great job, Andrea. Thank you. Have a great night.
You as well. Thanks so much.
Bye, everyone.
Likewise.
Helen,
Bye,
nice
everyone.
to meet you, Angie. And thank
Thank
you,
you.
Tamara.
Oh, thank you. Thank you very
Yes,
much, all.
agree.
Nice to meet you all.
You as well. Thanks all for sharing your experiences, and especially Tamara. Thanks so much.
You're
Right.
welcome. Have a nice evening, everyone. Thank you.
You too.